Hi, everybody. Dr. Nikita Vizniak here, and we are going to be going over the compartment syndrome of the lower limb of the leg, in fact, although you can have compartment syndromes potentially anywhere in the body. One of the key things that we're going to look at, though, is one of the most common and most significant ones for us to recognize in practice, and that would be an anterior compartment syndrome. So, what is it comprised of? Tissue blood supply in a closed anatomical space or compartment. The tissue pressure becomes greater than the blood perfusion pressure, and that means that the venous drainage cannot occur and pressure builds up with every beat of your heart, basically. So if we look at the leg itself, we can see there are compartments that we should be aware of. Number one, tibia and fibula right here, but anterior compartment is what we're going to focus on for today. You can have a lateral compartment, deep posterior compartment, and pretty rare but superficial posterior compartment. Other places you might see compartment syndromes are even in the low back. You can find them. I see them in rock climbers and bodybuilders all the time for upper limbs into the forearms and hands. So pretty much anywhere you have a fascial lining that's relatively dense, so dense, regular, or deep fascia, you can develop a compartment syndrome. You should know the structures in the anterior compartment because it directly relates to the symptoms that you will see on presentation. So for the anterior compartment, it's tib-ant, extensor digitorum longus, and extensor hallucis longus, as well as the anterior tibial artery, which will become the dorsal pedal pulse, very important for us to check, and the deep peroneal nerve. So you have to know the function of these compartments to identify these pathologies, or at least to get them early. Okay, so two main types for pathophysiology. Number one is an acute compartment syndrome, and let's be clear on this, it is a medical emergency. An acute compartment syndrome, you are looking for the 6 Ps: pain, paresthesia, pulselessness, paresis or muscle weakness, paralysis, which is full muscle loss of control, or pallor. It can be light or can even be turning dark blue potentially in some cases. Now, I have a couple of cases that I can go over with this where I've had patients where the ER docs have missed this when somebody's come in. The treatment is drastic. It is an emergency fasciotomy, literally a slice down the front of your anterior compartment to open it up, to decrease the pressure and get blood supply and oxygen back into that space. All right, so that's going to be our more medical emergency one, the acute compartment syndrome. If we look at the process, one of the risk factors for it does include fractures, but it can also be secondary to a cast that's too tight. All kinds of other things can lead to it. And it may be even genetic predisposition potentially. But if we're looking at this, the process is simple. You get edema, increased compartment pressure. This is decreased perfusion or venous drainage. It leads to ischemia, eventually can lead to muscle necrosis. If the tissue is broken down, you get release of osmally active molecules that are also going to keep fluid in there, and that's going to cause more edema. And then it just becomes a vicious cycle where you get stuck in this non-ending pathway until the tissue dies, or you actually die in severe long-term cases. All right, then you have chronic exertional compartment syndrome. And what do we get there? Characterized by exercise-induced pain, which is relieved by rest. This is most commonly what you're going to see. The specific etiology is poorly understood. There is an increase in volume. We all know that if you exercise, your muscles get pumped up, absolutely. And that can increase the pressure. And because it's in your leg, it's a gravity-dependent area, so you can see increased pressure that way. But the exact mechanism is poorly understood. But thankfully for most of these people, they recognize it once they go a certain distance or certain exertional level. They'll see their symptoms come on, they rest, and they slowly dissipate. All right, demographics, what do we see? Yes, 0.06% of the population, but suggest it may be underdiagnosed or misdiagnosed in a lot of cases. A lot of people are going to be calling this shin splints, and it is not shin splints. Do not use the diagnosis shin splints. Call it anatomically what it is. Generally, we see this in our peak athletic years, no difference male to female. There may be a familial predisposition, but the risk factor is repetitive loading or exertional activities. Increased activity by an unconditioned person potentially as well, and rapid increase in training level for conditioned people. So again, 10% rule. Do not increase intensity or time by more than 10% per week if you are training, and even slower than that if you're just getting into it. Okay, so history for the chronic exertional, what do we see? What is it? A runner who experiences gradual onset of pain. They usually run a certain distance and they start to get numbness. Typically, it could be 15 minutes, or they'll describe something like, whenever I pass this one tree, all of a sudden it feels like my leg will explode. I have a fullness in the front of my shin. There may be transient neurologic deficits that disappear with rest. You might see a possible foot drop gait. They'll say, yeah, I can't pick up my ankles. My foot feels clumsy, something like this. And here's another example, like literally after 2 kilometers, all of a sudden you have onset, okay, or a certain intensity level. And it should dissipate with rest. What else do we see on physical exam? The skin may look shiny if it is stretched out, possible foot drop gait. And in some cases, I've actually seen this before as well. You might have the muscle where it herniates through the fascia. And usually it's going to be inferior right around the medial malleolus, but it can be anywhere. Palpation, when active, the affected leg may feel full, often described as a woody sensation. And I say this as a joke, but it's a way to remember it. A male erection is an example of a compartment syndrome. You have a soft tissue area bound by fascial membranes. You increase the blood supply and pressure inside of there, and that's what an erection is. So this woody sensation there. Tenderness over the posteromedial or distal, what are we looking at? Yeah, basically posteromedial, what am I trying to say? Oh, I'd say lateral. Oh no, we're looking for the stress fracture here, pardon me. So if there is a coexisting stress fracture at the same time, then you might have tenderness over palpation of the tibia. That's all I'm trying to say here. Pain increase with active contraction or passive stretching during symptomatic episodes. Absolutely. If you try and contract it, it might be weak, or the contraction of the muscle may increase the pressure even a little bit more and it cause pain and symptoms as well there. For neurovascular, this is going to be the key thing. For the anterior compartment, you may lose sensation between the second and first toe, which is where the deep peroneal nerve supplies. You may also have a foot drop. If it is the lateral compartment, you may show loss of sensation over the anterolateral shin. This is going to be the superficial peroneal nerve. It is the deep posterior compartment. You may show weakness and loss of sensation over the arch of the foot, because that's going to be the sciatic nerve coming down to the medial and lateral plantar nerves. Well, I should say tibial nerve, if you're looking at that branch. And if you have a loss of pulses, you have to give this extreme attention. If the person's coming to see you, they've probably been relaxed for a while and they still have a loss of pulse, this requires more diligent evaluation. One of the key things I will say for this though too, the dorsal pedal pulse is often difficult to palpate. So you might try that tibial pulse instead, or look for your signs of the 6 Ps: pain, paresis, pulselessness. What are we going to go? Paresthesia, paralysis, and pallor. Differential diagnosis, intermittent claudication. Usually this will be bilateral. Deep vein thrombosis, this will be more of a calf type issue, or you might see it in the lesser or greater saphenous vein region. Lumbosacral radiculopathy, especially if they have foot drop, you'll do a more detailed evaluation. Again, I'd refer you to the specific video on that. Tibial stress fracture, again, specific video on that, but that's going to be history of repetitive microtrauma, where they haven't had time for their body to adapt, and it'll usually last for weeks, and you shouldn't typically see significant weakness or that sense of fullness in the lower extremity. Medial tibial stress syndrome, kind of along the same way. Peripheral nerve entrapment could be there. I got one case of a patient who came in and just literally tied their shoes too tight all the time, and they had numbness and tingling between their first and second toe where the deep peroneal nerve was. One of the easiest cases ever. Just don't tie your shoes so tight, or find a lace pattern that goes up a little bit higher or a little bit lower. Rarely you could see tumors. I just put it on the list just to make sure it's on your radar, but not something specific that you have to worry about usually. All right, special tests. Basically, it's an identification by physical exam in the vast majority of cases. However, you can measure the intercompartmental pressure if you wanted to, and you had the apparatus available to do it. You're looking at an increase of about 30 millimeters of mercury inside of that compartment, or 20 millimeters 5 minutes after exercise. This would give you actual measurements for it, but at the end of the day, if you suggest, or sorry, if you think there is any increase in that pressure, you are going to be evaluating and treating based on the presence of that pressure and thinking that they have a compartment syndrome. Diagnostic imaging may only be useful to rule out other pathologies, like bone scan to look at that stress fracture, or possibly an MRI may show it as well. Ultrasounds may detect deep vein thrombosis or muscle tears potentially. And X-ray might be useful if there is a tibial fracture, but your fracture screen is going to be almost as useful as that X-ray as well. MRI, again, for that detects edema, swollen compartments, but it's not specific for compartment syndrome. Laboratory tests, again, if it's a long-standing condition, you might see elevated creatine kinase with muscle breakdown potentially. But again, you should pick this up in your physical exam way before you're into these tests. All right, general measures in acute compartment syndrome, it is an ER referral right away. The sooner they get in, the sooner they get treatment to relieve that pressure, the better the outcome is going to be. If it is a chronic exertional compartment syndrome, you are going to be looking at modifying activities. Stop what's aggravating and then modify your activities and slowly build up tolerance. Switching over to other activities to maintain cardiovascular health, like swimming and biking. If they are unresponsive to conservative care and it continues to go on, you should consider orthosurgical evaluations as well to get the optimal outcomes for your person. Massage therapy is a great treatment option here. You can be looking at myofascial or instrument-assisted techniques that could offer some benefit, improving elasticity, just general range of motion. Joint mobs and manips, of course, referring to areas of compensation. So definitely focusing on ankle mechanics, looking at running ability potentially, and then, of course, evaluating low back, SI, hip, knee, all that good stuff. Fasciotomy has an 85% success rate for an anterior compartment syndrome, but it is an ER process and it is done as a last resort. Literally, you're cutting the body open to let air in there and the pressure out. Okay. All right. What are you going to do for treatment? Some recommend immediate post-surgical range of motion. That may include walking. I would be on that camp right there. The research seems to be pretty clear on that. The sooner I can get you moving, the better the outcomes are going to be. Light running after 5 or 6 weeks, possibly, and full activity 6 to 12 weeks. But again, this varies on the comorbidities and risk factors this person has. If they had poor cardiovascular health, if they were overweight, they smoked, all this could be delayed on your timeline here, right? Early mobilization as soon as possible to prevent scarring and adhesions. This is clear in the literature. You need to load this tissue early along lines of stress or the way that you want it to be able to move to see your best outcomes. If you want to go watch a video on scar tissue formation and treatment, go onto YouTube, type in Vizniak scar tissue. It is clear, over 100 references on that article. All right, prevention, poor biomechanics, such as overpronation, rear foot landing. Look at even the way they're wearing their shoes, avoiding hard surfaces while running, or even too soft a surface as well. If you've ever done it, if you run on sand right away, for me especially, I can just feel my legs just pump up right away, okay? Very hard work, so you want to do graded exercise exposure for that. Prognosis, early correct diagnosis and treatment. With early correct diagnosis and treatment, the prognosis is excellent. Misdiagnosis of a compartment syndrome can result in, of acute compartment syndrome can result in permanent disability, and in severe cases, even amputation and death for somebody. Now, luckily, that usually doesn't happen here in North America, but one of the key things that we want to be aware of. So number one, recognize this condition early. My leg is going to explode. I got the sensation of fullness. Number two, I've got the 6 Ps. I've got pain, paresthesia, paresis, pulselessness, paralysis, or pallor, or even, dark blue coloring as well. Okay. The affected leg may feel firm and tight and look shiny. That is enough for me to say ER referral right away. Now, if it is a chronic exertional type compartment syndrome, then this is something that we can work on more with our basic treatment options that we use in most practices that show what works best, which is going to be number one, patient education. Number two, empowerment for that patient. Number three, graded or alternate exercise exposure. And then number four, our manual therapies coming out to support that entire process. So compartment syndrome, great case. We can do a lot to help people, or at the very least, get them to the right place for the appropriate care. And I think that is a great condition. So I will thank you very much for your time, and I will see you in the next video.